So I've been treating endometriosis-related symptoms for just about 20 years now. And the three of the biggest questions that I get are, why do some succeed without surgery? Why are some more people successful post-surgery? And why should I consider pelvic floor physical therapy? And the answer to that is, and the research is now showing, that it does take a multidisciplinary approach to improve outcomes and quality of life, whether surgery is necessary, medication, whatever it is, but also doing these lifestyle modifications and pelvic floor physical therapy in conjunction with possibly acupuncture and dietary changes, which I'll go into briefly. The multidisciplinary approach that I'm mentioning, it does require medical care and proper medical care, as well as experienced and expert pelvic floor physical therapy. The musculoskeletal system, which is what we work on and what Dr. Shikande already went into a little bit, can affect bladder, bowel, sexual function, and can cause abdominopelvic pain. You also need to address the mental health, the behavioral modifications, the diet that I mentioned earlier, as well as exercise is extremely important, and postural modifications. Because what we find is a lot of the patients, they've been in pain for so long that they end up scrunching up in a ball on their bed, or when they're sitting, they hunch over because they're in pain. So we teach our patients how the tools that they can do so that they could sit upright better. We give them ideas to balls and bolsters and support systems to help so that they're more comfortable. Oh, the right one. Sorry. Got it. Okay. So pelvic floor physical therapy has proven effective for patients with endo. It helps to free up adhered tissues due to the endometriosis. It doesn't get rid of the scar tissue, but it helps to break it up. And that's with or without surgery. This is needed to optimize abdominopelvic tissue mobility. It can help with urinary bowel urgency, frequency, retention, nighttime frequency, sexual health, as well as improve quality of life. We already went over a picture of the pelvic floor, but these are the pelvic floor muscles up at the top. And then you can also see the abdominal area at the bottom in the bottom picture. And that's not including the organs that are in the abdominal wall. Those are all the muscles, nerves, the arteries and veins that can be affected from endometriosis, as well as musculoskeletal dysfunction. And then to the left picture is just a picture of scar mobilization that needs to occur in order for the tissues to move better. Oops, sorry, this is sensitive. This is just another example of trigger points. I think Dr. Shikande mentioned. So this is, to the left is a trigger point just in the abdominal wall, the iliopsoas muscle. A lot of the abdominal wall muscles that were already mentioned, the obliques, the transverse abdominis, they can refer pain into the abdominal region. They can refer pain into the ovarian area, and a lot of patients may say, I feel like I have ovary pain, but yet it could just be a trigger point in the iliopsoas or the quadratus lumborum muscle that's referring. And then to the right are other trigger points. I don't know if you can see well, but there's X marks. You press on those areas and it refers pain into the sacrum area, to the tailbone area. So it's really important as a pelvic floor physical therapist and as a physiatrist that they assess the various trigger points, because that could be a cause of a pain. And if we could help reduce some of these symptoms for you, it can help with your overall quality of life. What are the pelvic floor muscles? We already went over it a little bit, but they're basically, the function of them is to support the abdominopelvic organs. Also, it helps with sphincteric control, so bladder, bowel, continence. The muscles help with sexual arousal and performance, and that is very important with for everyone's quality of life as well as it helps to stabilize the core. So if there's dysfunction in these muscles as well as the abdominal wall, it can result in bladder, bowel, sexual dysfunction, or abdominal pelvic pain. So again, some of the bladder symptoms and bowel that we see as pelvic floor physical therapists are urgency, frequency, retention, incomplete emptying, where the muscles aren't able to relax enough to allow the bladder to empty, to allow the bowel to empty. So the patients may also complain of pain or constipation, irritable bowel type symptoms. So these are all things that we see in our practice. As well as sexual dysfunction, they could complain of pain at the opening, the vaginal opening, or they can complain of deep penetrating pain, and that could be, again, where the trigger points are that I showed you earlier. As well, abdominal pelvic pain, they could have trigger points throughout the abdominal wall, nerve irritation, the ilioinguinal nerve, the genitofemoral nerve. Any of these nerves can be irritated from the endometriosis because of surgery or all of the above. What is the difference between the overactive or hypertonic pelvic floor muscles and underactive or hypotonic pelvic floor muscles? A lot of people are familiar with Kegels and strengthening the muscles, but with the overactive pelvic floor muscles, you actually don't want to do Kegels, and I'll go into that in a little bit. But the underactive is more when there's leaking from coughing, sneezing, lifting. That is appropriate for doing pelvic floor exercises or Kegels. But again, if you have overactive muscles, you should not be doing pelvic floor repetitive exercises. There we go. So as the symptoms that we see and the syndromes that we see symptoms of endometriosis, we see post-surgical and scar adhesions, the abdominal pelvic neuralgias, vulvodynia, vestibulodynia, clitoridynia, pelvic floor tension myalgia, coccydynia, where there's pain in the tailbone area, painful bladder syndrome, bowel disorders, and fibromyalgia, as well as TMJ, or jaw pain. And then addressing the vicious cycle is so important, as we already have mentioned. But basically, whatever the onset is, mechanical, trauma, postural, or surgical, that can create inflammation and scar tissue, which can decrease mobility of tissue, muscles, nerves, and organs, which can cause pain and or weakness, and the emotional stress, and the cycle continues. So as pelvic floor physical therapists, we look at the body as a whole. We look at the posture, the structural alignment. Is there scar tissue, and is there mobility around that area, in the viscera, in the organs, around the nerves? Are there restrictions that are contributing to your pain? We look at the trunk, back, hip, leg, abdominal, range of motion, as well as strength, movement patterns, motor control of the pelvic floor, but not just the pelvic floor, the entire body. Or is someone walking with an altered gait because of pain or because of back dysfunction? As well, we look at a functional assessment, sitting posture, standing posture, and their exercise routine. And then treatment, we assess the tissues and the muscles externally, but we also assess the muscles internally. And a lot of patients have questions about that because they are fearful that it's going to be painful. But as a pelvic floor physical therapist, experienced pelvic floor physical therapist, we gauge the patient's tolerance to any type of massage techniques, and we work with the patient to make sure that they're comfortable and also that they're not fearful of pelvic floor physical therapy. We'll give dilators for home use, as well as show the patients manual techniques to do at home with or without a partner. And in addition, we do skeletal, neural, or nerve, and visceral or organ mobilization. We also do biofeedback, but that's not the only thing we do. Biofeedback doesn't always require a machine or that sensor that you could see there. It sometimes is just talking to the patient, whether they're contracting the muscles when they shouldn't be, relaxing the muscles, or having a difficult time relaxing the muscles. That's a common thing that we see in the abdominal wall as well as the pelvic floor. And that can also keep the cycle going with the endometriosis pain. So again, it's really important to address all these different factors, teach relaxation techniques. We teach the patient we help them to downtrain the pelvic floor muscles. And some keynotes, and I'll repeat this again, straining aggravates the pelvic floor and abdominal wall. If you have trigger points, it can make it worse. And then Kegels can also make your symptoms worse, because if you already have shortened, tight, and painful muscle, doing repetitive exercise can make it worse. So I explain it to a patient as if they had back pain or back spasm. If you go and you have a trigger point there or tightness, and you go and you do deadlifts, it's going to make that back pain worse. So it's similar with the pelvic floor muscles. If those muscles are tight and shortened and painful, then doing Kegels and repetitive exercise may just exacerbate that pain. Another thing we teach the patients is specific stretches. So some people, this is another question I get asked frequently, why when I do this stretch does it hurt? Well, I'll tell the patient, well, it could be because you have tight tissue or trigger points. So let's figure out other stretches that work for you and help with your pain. We also go over alignment and posture. That's important. So whether you're at home, at work, or wherever, making sure that your setup is as comfortable as it can be with cushions or a back support. We also go over sexual positions, because that can be a cause of stress and pain, and certain positions can actually help decrease pain, but again, it's dependent on where the pain is. So for some person, it may be propping the knees up with pillows. For another person, it just may be a different position that helps them. Strengthening is important, but it should be pain-free, because if you have trigger points or pain in the abdominal wall and you're doing repetitive strengthening exercises, same thing I mentioned before, that can actually exacerbate your symptoms. So trying to do strengthening exercises that are not painful or don't increase your pain is really important. As well, if there's any abdominal wall separation, it's important to address that and close those muscles. So that may be something that a physical therapist would have to teach you, but it is something that you can reduce. Addressing back and hip function, as well as closely monitoring all the above and getting the patient back into exercise, whether it's 5 minutes of walking twice a day, swimming, whatever it is. Exercise is really important, and whatever you find works for you, whether it's yoga, tai chi, or walking, it's definitely important to keep trying. Eliminating poor bladder habits is important, so not going to the bathroom just in case. Obviously, if you're getting on a subway, I understand, or if you're getting in your car, but if you're constantly going to the bathroom, it confuses the signals that go to and from the brain. So making sure that you learn how to control the urge for the bladder, trying to use breathing techniques to calm the bladder down, not hovering over public toilet seats. I know it's a hard thing to do, but put the tissue down, put the toilet paper down. Make sure you are drinking enough water. A lot of patients are dehydrating themselves, makes the bladder more irritated, makes the bowels more of an issue, because then they become constipated. So making sure you drink enough water and avoiding bladder irritants if it bothers you. If you have that cup of coffee a day and it doesn't bother you, that's fine. Or if it doesn't bother your endometriosis symptoms, or if you need low acid coffee, whatever it is, but definitely finding the irritants that are making things worse to avoid them. And then the bowel, I know, pretty picture, but most people don't know that your bowels should look like type 4. They think that type 1 is a normal thing, but it's actually can make that is considered constipation when they're small little pellets. So making sure that the bowels are soft and smooth and easy. You can use a squatty potty. I'm sure many of you are familiar with that now with the unicorn. Relaxation techniques. We teach abdominal massage to the colon to help with bowel movements. As well, a proper fluid and fiber intake. Nutrition is key to not just endometriosis and inflammation, but also to help with the bowels and help with decreasing any bladder pain if you have any. As well as with the bowels, also time voiding, going at a certain time of day. And again, no straining and no breath holding. That will just keep exacerbating any abdominal pelvic pain that you have. Other modifications Dr. Shikande already mentioned a couple, but having appropriate cushion if you have any sitting pain, if you have back pain or abdominal pain, using a back cushion. Some people sit on a physio ball because it's just more comfortable and they don't feel so pressed up against a chair. The sexual position modifications that I mentioned earlier, using lubricants that work for you that are non-irritating, using supportive belts that help. Standing frequently if you have a sitting job is really important. Changing position is also really important. So my patients that get on an airplane and they say they have that it's uncomfortable riding on airplanes, I tell them to bring in extra, to either bring your cushion, bring an extra sweater, tuck it under you, try to find different positions that feel okay during your flight, as well as stand frequently. Education is extremely important. Sex should not be painful. Abdominal pelvic pain, really trying to learn how to reduce the pain and figuring out what works for you is important, as well as cardiovascular, I mentioned, and self-care. And then home exercise is key. As a physical therapist, yes, we do see you once a week, sometimes twice a week, but a home exercise program is so important. It's the first thing that I give my patients. I give them as simple as just a breathing exercise and trying to relax the pelvic floor, trying to relax the abdominal muscles. I encourage trigger point balls or massage balls. You could take a tennis ball and use that. A massage stick, dilators, I do encourage you to see a pelvic floor physical therapist to learn how to use. Different stretches, using heat, using ice, whatever, again, works for you. Yoga, mind-body therapy, mindfulness meditation, I'm a big fan of for those that it works for. Some people would prefer to do yoga. That's fine as well. But figuring out tools that can help when you have an increase in pain is very important. And then key points, multidisciplinary approach. Not all physicians are familiar with how to diagnose abdominopelvic floor dysfunction, trigger points, and nerve irritation. Your physician may not prioritize these symptoms that you're describing, especially if you don't inform the physician. So telling your physician as well what you're experiencing is really important. And if they don't know what to do, then hopefully they'll be able to refer you to another physician or pelvic floor physical therapist. As well, bladder, bowel, sexual dysfunction a lot of times does require pelvic floor physical therapy. But most people don't realize that, but it is a very effective treatment for those that have musculoskeletal dysfunction. In addition, treatment takes time. It depends how long you've had your symptoms, how compliant you are with a physical therapist and with the physical therapy and your home program. You should see improvement within 4 to 6 weeks, 4 to 8 weeks, even a small bit of improvement. If you don't, talk to your physical therapist, tell them what's going on. Hopefully they can modify something so that you start to feel some relief. If not, then you may want to get a second opinion from another physical therapist. Again, no Kegels, no straining. This may only exacerbate your pain. And physical therapy can reproduce your symptoms, and that's actually a good sign because that means that those areas need to be treated. But over time, those symptoms should be getting better with the physical therapy. They should not be getting worse. And that's it. If you want to find a pelvic floor physical therapist, these are 3 websites that you could look at. Herman and Wallace, the American Physical Therapy Association, Women's Health, and the International Pelvic Pain Society. They all have a find a provider on their websites. And again, I have the book and DVD for sale, and it goes towards the ENDO Foundation. And the middle picture is of what Dr. Shikande was going over, the central sensitization and peripheral sensitization. That is a book that helps for you to learn how to manage those symptoms as well, and trying to downtrain the whole nervous system. And the Pelvic Messenger is a free blog talk radio show. This is just a quote from a patient, actually from a long time ago, when I personally was first realizing how important pelvic floor physical therapy is for patients with endometriosis. So she basically just said that after she did have surgery, but she also was still having a lot of symptoms, and after the physical therapy, her symptoms got significantly better, and she was able to go back to a normal lifestyle. And that is it. We did declare May as Pelvic Pain Awareness Month, so look out for some tweets and different things going on in your area. Thank you so much.
Next, we have Dr. DeGregorius, who is a pain medicine and spine pain specialist. He trained at Notre Dame and University of Michigan, as well as Cornell and HSS. And Sloan Kettering. We're happy to work with him at Lenox Hill as well. Thanks for coming.
Thank you very much. Good afternoon, everyone. Thanks so much for the invitation today. I think this is an important topic to consider. Thanks. And just by way of introduction, so my name is Jerry DeGregorius, and I'm a board-certified anesthesiologist. So my background comes from general anesthesiologies with an emphasis on the physiology of the body and especially how the peripheral nervous system interacts with the central nervous system. Because in anesthesiology, we really have to understand how procedures and medications interact between the two parts of the nervous system. Because from a surgical perspective, when surgeons are doing things to peripheral nerves are firing and producing pain. So we need to figure out a way to modulate some of those pain impulses from the central nervous system to, in the operating room, produce what we call anesthesia. And one of the components of anesthesia is pain control. And for this talk, we'll be focused on specifically how interventional, usually needle-based procedures can mitigate the painful symptoms that ordinarily would go and be perceived by the central